All right. Good morning, ladies and gentlemen. Thank you for coming today. By a show of hands, who can hear me? Fantastic. Am I loud enough? Yes. Am I too loud? Fantastic. Okay. So, first thing I want everybody to do is honor your mind by being here. Give yourself this time, this period to be in this session. Put away your phones, put away anything that's distracting you, taking your mind away from being present here. And everybody, just so we can really focus our minds, we need to give it oxygen, right? Our brain needs oxygen. So everybody take a collective deep breath in and release it out. Good. One more time. Deep breath in through the nose and blow it out. Good. So, today I'm really excited to be here with all of you. My name is Laura Geisenheimer, and I'm a speech pathologist here at Edgewater, where we all live. So, what we have in ACTS is something really special called Accentuate the Positive. So, these are things, and our dates are 2021, 2022, it just is ever present. So, we're always accentuating what's good, and we're trying to keep it good and thrive with that. So, did you know, anybody here, that you could continue to exercise your brain from the time you're born until the time that your life ends? Yes. You can continue to exercise it. Do you think, by show of hands, how many people think it's possible to prevent a decline in cognitive functioning? Sure. So I heard something really interesting. Yeah, depending on the circumstances, right? So sometimes it depends on circumstance. But ultimately, and we'll talk about it, we can prevent cognitive decline. We can prevent our brains from having a negative deterioration. So that's what we're going to talk about today, how we can take charge of our minds to build our cognitive reserve. So, what is cognitive reserve? Well, ultimately, we'll be talking about what it is, why it's important. Does age really matter? Does it matter if I'm 20, 50, 90, 60, 82? What are my risk factors for this cognitive decline? What can I do, that means each of you as individuals, to build my own cognitive reserve? How can I empower myself? And then the last thing we'll be touching on is how rehabilitation can help you to do that. And that's where me and my team come in. So let's get started. Cognitive reserve is the mind's resistance to damage of the brain. So our brain's ability to face different types of damage, deterioration, or illness and maintain cognitive function. People that build higher cognitive reserve age more slowly than their peers, and this affects our entire neuropathology, regardless of our genetics or environment. Working the brain does help build this cognitive reserve. So, is it a use it or lose it, or is it cognitive reserve? Are they the same? Well, not really. This does not hold true for cognitive reserve. So, yes, if you don't use it, you'll lose it, right? If you stop walking and you really don't try at all, or you physically cannot, you might lose those potentials. If you don't ride a bike anymore, probably you won't preserve those skills. So, if you don't use it, you'll lose it, absolutely. But there's another level beyond that. That's called cognitive reserve. So, that's not just think or you lose it. That's go the extra mile. So that's do something else that's going to really build that cognitive reserve. And there's something called the cognitive reserve hypothesis. And this hypothesis states that you can do certain types of cognitive training that can build more pathways in the brain so that when there is an injury, illness, genetic tendency towards dementia, or other kinds of deficits, that we have more pathways already created to compensate for that than somebody who hasn't. A person with lower cognitive reserve will decline with cognition, physical, and social abilities at a faster rate than somebody without this cognitive reserve. So another way that I heard once and I found really helpful for me to understand is, think of cognitive reserve as a gas tank, okay? And think of your gas tanks in your cars, whether you have them now, whether you had them before, whether you've been in one recently. We all know there's a gas gauge, and when you run out of gas, you're in trouble. You have no more gas, you're stuck on the side of the road. But the manufacturers built in some neat little trick where even after the empty, there's about 5 gallons of cushion, right? 5 to 10. So we all kind of ride it out. We say, oh, I still have 5 miles left. Well, that's your cognitive reserve. So if that gas gauge does get to that empty mark, maybe you were diagnosed with dementia, right? Well, that reserve you have, it's cognitive reserve. It's something you've built up as a capacity to protect yourself, your brain, your body, your mind. So in The Importance of Cognitive Reserve, they talk about a study where there are 2 80-year-old women, as you can see here, that have the same brain injury, but one is presenting with more advanced signs of deterioration than another. And after these 2 women pass away, they do autopsies, and they found, lo and behold, that both of these women actually had Alzheimer's, which you can't yet still diagnose. The only way we can diagnose that is post-mortem these days. And maybe that will change. But both of these women had Alzheimer's. So if I were to ask you, why did one of these women present like she had significant deterioration and the other one did not? Cognitive reserve. Well done, Judy. So cognitive reserve helped this woman to preserve. She had more life experiences, maybe more higher education, maybe additional environmental stimuli based on groups she was attending, social gatherings she participated in, cognitive challenging tasks. Had she not challenged her mind to that extent, she may too have shown more signs of deterioration, lost her ability to walk, to talk. Not saying that would never happen, but maybe it was slower. So this is all thanks to cognitive reserve. So if I tell you now, why is it important to build cognitive reserve? Based on what I've told you so far, what are your thoughts? Sounds good, okay, yeah? And, okay, so, yeah, that's a great question. So how do you build this cognitive reserve, right? Well, think of it this way. We're going to talk more about it as we go, but it's important to get yourself outside of your box of normal reasoning and processing, of normal functioning. And I tell a lot of people this. A lot of people in this room know me, and that this is something I'm very passionate about. And I always talk about routine. So in some ways, our bodies love routine, right? Who thinks they love routine? We all do, because guess what? If I said, you're all gonna wake up at 4 o'clock in the afternoon, dinner's not here, you have to go find it yourself, I changed your whole wardrobe, and actually we're not calling this Edgewater anymore. Everyone here would go, what? Right? Because we know what we know and we thrive on that knowing. But at some point, the knowing, we know it. And we're doing the same thing over and over and over. And to an extent, that helps us thrive and live, but it doesn't help us go beyond. It doesn't help us build that cognitive reserve, right? So before I get to how we do it, does age matter? Well, some scientists believe cognitive reserve is an active basically coping process that's built up over a lifetime. So what you do in life can contribute. So does age matter? Sure, age matters. You might actually even be better off in your 60s because you have more experiences, more knowledge, more wherewithal to deal with certain situations. So sure, age matters. But does age matter in the extent that you can't do it anymore? Absolutely not. Absolutely not. Scientists believe that even at an older age, based on research, based on studies, that you can make these changes. What are risk factors for this cognitive reserve we're talking about, that we'll talk about how we can build? What are your risk factors? Well, hearing loss, we look at it and we say, why does that matter? Well, who thinks they know why that would matter? Sure. Yeah, I heard two great things. So you're not absorbing the information, and there's less communication, right? So sometimes we think, well, my hearing aid's not working, but that's okay. I can hear well enough. It's fine. You know, the other one's not working so well either, but it's okay. Well, guess what? Over time, you start to become inured to that not working, and you're not as sensitive to the things around you. And you're not hearing as much of that input, like Les was saying, and you're not getting as much of that communication. And so the challenge to the brain starts to diminish. So the less you're hearing, the less stimulation you're getting, right? And now we're not talking about people that were born without hearing. We're talking about people that have had hearing and are losing it, right? So a sedentary lifestyle with low physical activity, so you're not challenging yourself. The entire body's connected. Nobody I work with likes to hear it, but it's true. Your brain does not exist independently of your arms, of your legs, of your swallowing muscles, of your breathing mechanism. They all exist connected. Fortunate and unfortunate. Diabetes, heart disease or high blood pressure, advanced age, low educational level, depression, obesity, smoking. Now, if I had asked you all, do you think these could be risk factors? You would all say, of course, yeah. Those are I've heard it from my doctor my whole life. This is dangerous. Yeah, blindness, so losing your vision, yeah, absolutely. And that can happen from a number of things. I mean, diabetes can be responsible. It can be a certain disease you picked up. It could be a million things. Yeah, absolutely. So the more input you're getting, visual, auditory, it's all important. And the more you're able to synthesize it and be present with it. So we've talked about risk factors. We've talked about what it is. Now we want to talk about how do we build it, right? We're talking about here more than routine. And as soon as you look at 1 through 4, you'll see it's more than just your routine. It's something above and beyond, right? Because how many of us in this room can raise your hand and say, I've learned a new hobby in the last month? Two of us. And for the 95 channel, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 people in this room. 2 of us said, we did that. Well, is that a judgment? No. But it's an interesting thought on, am I going that extra step? Or am I just existing in my everyday circle and not challenging my brain more? Learning a second language, wow. Well, we all say, I can't do that. Who doesn't matter? I'm already in my 80s. Who cares? I'm not going anywhere. Why? I think it's phenomenal. There are all kinds of internet access things you could get. You could travel through the internet. I mean, you could learn, you could talk to your grandchild or your child who lives in another country in the language that you want to learn, even if it's 2 words that you said in that language. You could exercise your mind and body together. So I think a lot of you who've been in a physical therapy program in our department here have done something to this extent, right? So the most basic example I can give you and continue to talk to you about while not falling over is for me to walk and do a cognitive exercise as I walk, right? So I'm going to challenge myself to come up with as many types of hobbies as I can while I walk with my high knees. So I'm going to say working on? No. I'm just saying in that prescribed setting, you're challenging both at the same time. And it becomes very hard. And at this point in your lives, if I said to each of you, raise your hand right now and say, you could probably all do it. Well, unfortunately, when you have marked cognitive decline, you can look at me and I can be a mirror to you and you may be able to do this, but doing both at the same time is very nearly impossible. Seems so simple though, right? So these are the things we're talking about. And 4 is, these are not all of the ways, but they're 4 that we're giving you. 4 is work with us here in the rehabilitation department. Now, rehabilitation doesn't always mean rehabilitation in the sense that you are coming back from a stroke or a fall or having hit your head. Doesn't always mean that. It can be building cognitive reserve because you are pre-rehabilitating your body for what could happen down the road. So some of the other examples they give here and things that we work on in therapy are sustained attention, topographical orientation, cognitive flexibility, categorizing information, things like that. All of these are very, very functional, very person-centered tasks that we come up with. And so we use each of these to build your cognitive reserve. Now, if I did sustained attention and I had to gauge everybody in this room, how is your sustained attention? Aside from the fact that most of us in the Western world and the world in general have monkey mind and our thoughts are on, oh, I have to pick up my lunch at 12 because, and I know I'm supposed to meet Jackie at 5. Aside from that, you're all pretty well sustained. Your attention, your eyes are looking up here, you're focused, you're oriented, you're engaged in some way, right? Maybe that's not one that's for you, or maybe it is. Maybe it's switching between tasks. Maybe it's that you're doing something and then you pick up something else because you have to divert your attention and you can't process that fast change. Maybe not. So there are a lot of different things. There's working memory, which is preserving information in your mind, sometimes manipulating it, and then being asked to recall that information in either the same or a different format, now or in 5 minutes or in 10 minutes. How many times do we get a phone call and we say, oh, dinner's at 5:30 today. Yeah, okay, who's coming? Yep, Roz and Ray. Yeah, okay, great. And we hang up and we have so many things and we say, what time is dinner today? I know they just told me dinner was at what time, and it's gone, right? So the working memory, holding on to those things. There are also other things that can help you that we use collectively. So one of them is rehabilitation, which kind of falls into all of these patterns here, every realm. Social support, positive affect, education, modifiable health factors. But there are also things that you can be doing on your own, right? You can be adding something new to your schedule. You can be doing a novel experience of sorts. That can be anything. Who can think of one novel experience right now that you could do within this building that you haven't done before? I think we've all walked the halls, but maybe some people haven't. We all have to walk to get to our apartment, right? Inevitably. I mean, you can't get there without either walking or rolling or something. What's something you haven't done here that you could do today or this week? Swim? Yeah, Roz? Steps like doing stairs? Sure. Judy? Well, I have and that's a big task in and of itself, right? I mean, you've got to focus on it. You've got to attend to it. You've got to sort, make decisions, come back to it, manage. It's a management task. You're managing a lot of things. How about joining a mahjong game? Or, I don't know, going on a bus trip? Or sitting with someone new at dinner? Because it's super easy to talk to the people you always talk to and you know. But sitting with someone else is a real challenge. You have to stop. You have to ask them their name. You have to engage in brand new conversation. It's not comfortable anymore. Yeah.
I have catalogs here for lifelong learning at us to some of.
That was wonderful. So I will share that again for anyone who didn't hear that. I'm sorry, I don't know your name. Anne. Anne was sharing that she's been taking lifelong learning at Florida Atlantic University and that she has a lot of pamphlets and that this group or just herself that is doing this wants to get as many people as possible together so they can take a group van there. I think continued learning, education is fantastic. We are always and should always be learning. And if we have turned it off, we're missing out and we're closing ourselves and we're not engaging in that cognitive reserve building and we're narrowing our path to a more dangerous future. Could be. So that's essentially the crux of today. Building cognitive reserve can be done in so many ways, but we in rehab especially have building blocks to help you do that. Yes? That's a very, very good question. So the question was, can you help someone that has Alzheimer's to rebuild was your word. And the short answer is no in terms of rebuilding, but can we help language preservation? Yes. So one of the things that I explain to people is that there are essentially three main compartments you can think of cognition in, and they're not nearly as limited to this, but this is how I can help you see it. There is within functional limits, meaning we're not perfect, nobody's perfect. I'm not perfect, no one in this room is, but you're functioning pretty normally, you're able to get through your day. Then there's mild cognitive impairment, okay, that's our number 2 here. And our mild cognitive impairment is, I'm starting to have some trouble. I'm sort of doing more than the traditional just, where did I put that? Oh, I know I came into this room for something. It's a little worse than that. Your family starts to notice a change. Your friends start to notice you said the same thing 3 or 4 or 5 times. It's a little bit more problematic. And then there's 3. Okay, this is where you've actually been diagnosed with a dementia. And dementia is an umbrella term. So Alzheimer's, Parkinson's dementia, frontotemporal dementia, Pick's disease, they all fall under dementia. Unfortunately, once you've developed one of those, which is called a major neurocognitive disorder, you can no longer make new memories. The brain does not do it. What we can do in that point is not abandon this person and say, well, no more new memories, can't help ya. What we do every day and what people know us for as rehabilitation is working with this type of individual in this type of condition to preserve the ability to communicate. Because communication is key. I want to not only receive information, but output information. And not only output, but receive. And maybe it's not done verbally anymore. Maybe it's done with pointing to a picture or blinking if you're physically incapable. Maybe it's just done with a look left or right or a smile. Someone can convey whether or not they want apple juice or orange juice by looking at it and smiling. So there's so many ways to convey language, but the answer is no, which is why it's so important to build that cognitive reserve. Most people that I would say I've found in this building are hovering in 2, 1 and 2. And no one wants to admit they're in 2. And to me, I encourage you to admit you are in number 2. You are in the second realm of mild cognitive impairment. I encourage you, if you feel you are there, to not be afraid of it, to lean into this knowledge and to lean on the team and the community that you have here to make these changes while you still can. Because in that point, you can rebuild those pathways. You can build a cushion for your cognitive reserve so that if you are diagnosed with dementia next month, you have built a new set of neural pathways that will cushion that deterioration. Does that make sense?
Yeah. Have what they have and not
Yes, so we try and preserve. So we try and, like I mentioned, language, we try and preserve it. We try and stimulate that language as much as possible. Yes, yes, we try and stimulate whatever's there to the best of our ability. And it's across the spectrum. It's hearing, sight, sound, touch, everything to keep hold of what you have. Ultimately, that person that does have a major neurocognitive disease, though, will at some point lose that because the brain slowly loses until the point where it can't function anymore. But we are all learning that we can avoid, in large part, that extensive situation. We can prepare ourselves, and we do it in our food. We don't all go out and eat fried junk food, pizza, chicken, fries 7 days a week. We're like, oh no, I've got to drink water today, and I'm going to have a salad because I did have a cookie before. But we don't do it for our brains, do we? We try and take care of our bodies, but we don't take care of our brains the same way. So that all being said, I know it's a lot of information in a small chunk of time and presentation. Does anybody else have any questions? Rudy? Do we take complaints? I take complaints all day long. Mostly from myself, but yeah, I take them all day. That we don't have that class now. We did have a class here. And actually, thank you for bringing it up. It's not, for those of you who don't know, and Channel 95 and anybody else in this room, we had a once weekly, hour-long, more or less, class. And it wasn't just a class like I came up and did a word puzzle like many people could do. There was a skilled clinical component to it, which made it unique. Unfortunately, because of time constraints and scheduling, I did not make the decision, but we as a company did have to discontinue that. Rudy's verbalizing that he is frustrated that there is no such class currently, but since you did bring it up and Roz had asked me a question, we are resuming that in October. So that will be not full-time, but it will be once a month, 1 day a week. So it will be once a month instead of every Monday, it will be 1 day. It may be Monday, we haven't decided yet, but we will let you know. And this will be in October. Yeah. That's a question I would ask Stephanie. I'm going to refer you. You know where to find her. So you know where to find her. I'm going to refer you to Stephanie, okay? Stephanie Weiss. Yeah. Yeah, sorry, Jane's hand was up and I'll come back to you. Yeah. You know, I do have a microphone here that I could have given to you had I figured out how to use it sooner. So, go ahead.
I was just saying that there's research on the microbiota of the gut that can directly affect the brain and memory, and it's pretty new. So diet can affect, yeah, the brain cells in it.
Yeah.
And also music is what you know. Music is another thing that we already know.
Yeah, absolutely. So yeah, as Jane, thank you for sharing, was saying that the gut-mind connection is something that's being heavily researched now and is really quite fascinating and encouraging because we can do things with our food, with our exercise, of our brains and our bodies that really can support our overall functioning. So thank you for sharing that. Judy.
Are you going to tell this audience about the program?
Yes, I am. Thank you. Do I have any other questions? Roz. I believe so. Yes, I have it recording currently with Ellen, and she'll help us get that out to the community again. Because I think part of the problem, a big part of the problem is that a lot of people don't know what we do and what's available. And it's right at your fingertips. And so to kind of segue from that into what Judy was asking is we have a program that doesn't necessarily work on, well, I had a stroke and now I need to get rehab. What you can do is you can say, you know, I'm noticing a little change in my cognition. I'm a lot more forgetful than I was. I'm really not managing my calendar so well. I'm feeling kind of overwhelmed by the things that used to be pretty easy for me. I'm really not thinking of words as promptly as I was. They're just kind of not coming. And it's kind of scaring me. And I think instead of reaching out, we often run away. So if you were to take that and reach out and contact your physician to get a prescription that said, you know, I really think I need a speech pathology evaluation and treatment. That would be the best first step. So your doctor would write you a prescription, speech therapy, evaluation and treatment. You would bring that to our department. We would run your insurance, and we would do an evaluation. After that evaluation, I would review with you. You know, it looks like everything is perfect. Everything is A-okay. You're functioning 100% out of 100%. Almost never the case because none of us are perfect, right? So in that case, you might say, you know, I know my standardized test shows that because that's what our world is, right? Medicare standardized testing. Your doctor goes by a standardized test. But even though that's normal, you still find these shortcomings that you're frustrated by because they didn't used to be there. So you say, but I'm still really interested. And I say, okay, well, we can still do therapy. Unfortunately, your insurance doesn't cover it, but there is a private pay option. Now, you can do private pay individually or as a group. There are group options. So there might be many people in your situation that have decided, I want to pursue this, but I don't show as having a decline yet in standardized testing, but I still would like to do it as a group or on my own. The alternative scenario is you get your prescription, we do an evaluation, and I say you're testing at about 85%. Not terrible, but we have work to do. And I say to your insurance, I need 3 months with this gentleman or this woman, and I would like to work with you 3 times a week to intensely target those areas that you feel are not really optimal, are not where they were, and that are really scaring you, and that we're running from instead of seeking help for. And in that case, we could do 3 months of therapy. You could see tremendous change. You could see a little change. We may extend, we may not extend. But ultimately, we're going to come to the point where we finish therapy, skilled therapy with a clinician, me, or another clinician, and you say, you know, I really feel invigorated. I made so much positive change. I want to keep doing this. It's like continuing to go to the gym, but you're doing it for your brain. So now you say, well, I do want to do that private option, and I want to work with you once a week alone and twice a week in a group, and I want to continue to target my cognitive reserve, which we talked about. Because in 5 years, as I become a little different, because our bodies constantly change, we feel a little peace of mind that we have this cushion to fall back on. That also is a lot of information I just gave you. Yes? Absolutely. 100%. A neurologist will write a prescription for an Alzheimer's patient, was the question. Your general practitioner can write a script for me. Let's say you feel, this is aside from cognitive reserve, let's say you feel your voice isn't loud enough, or your swallowing isn't normal, like you're coughing when you're eating or drinking, which happens to everybody, once a month, maybe. Every day, not normal. Twice a day, not normal. It shouldn't be happening. So you can get that from your primary care doctor. If it's your voice, you can get it from even an ear, nose, and throat doctor or your primary doctor. The whole idea of the healthcare system is to help write scripts to the people that can do that particular intervention. So yes, to answer your question, a neurologist can write a script for an Alzheimer's patient to be treated. Yes, Roz. Yes. Yes, so Roz is asking about basically a random targeted screening that I did for targeting swallowing in particular. So a lot of us, whether or not we want to admit it, in this building have trouble swallowing water and other foods. We cough when we drink water or coffee or tea, or we feel like the food is not going down when we're eating steak or chicken or bread that's dry. So I did a random setup in the lobby where I gave people a 3-ounce water test, and I had everybody drink 3 ounces of water and see if it made them cough in that moment. Now, does that mean you have no trouble if you were fine? No, but in that moment you're okay. That was an informative screening educational event I did. My goal is to do those once a month for different things. So to vary it between voice, swallowing, cognition, so on and so forth. And I will post them before they happen. I have not done that again. You're correct. You're correct. Yes, Anne. That's very interesting. I don't know about that study, but for anyone that didn't hear that, essentially there is a connection in this study to the driving of your vehicle over time and how it may or may not correlate with dementia or cognitive impairment of sorts. So I don't know anything about that study in particular, but it does seem very interesting.
That's also in the booklet.
Very nice. Great. Any other questions that anybody has? No question is silly. No question is too much. Yeah. Correct. So, absolutely. So, any evaluation that we do here requires a prescription from a physician. Absolutely. And then from there, we take it and we address the rest. So, for cognition, The physician would come from the prescription would come from your general practitioner, your primary care physician. Okay? If you see a neurologist can also write that, but you wouldn't get it like from your kidney doctor because it's not kind of related. But your neurologist deals with neurology, so does a primary care physician. I have one more question back there.
Also, just to add, if you do go to the clinic and you're seeing Cheryl, the nurse practitioner in the clinic, and you see her for an appointment and you schedule an appointment, she can also write the prescription, so you don't have to go to your doctor. But
If you have seen her before.
you would have to go to see her to become, a patient of hers. Actually, is an added bonus because then you don't have to go out to your doctor. But if you're seeing her or you want to go see her for an
So I'll say that for the 95ers who maybe did not hear it, Channel 95, and for the recording, that Stephanie was mentioning that if you do see our in-house nurse practitioner, Cheryl Homer, and she follows you as a patient, she could write this prescription for you as well. Again, that's only if you've seen her and she treats you. You can't just go in there and never having seen her and ask for a prescription. All right? Yeah, Tammy had a question in the back. That's a great question. So the group would start at about 2 people, because that's more than one, yeah? But I would have to say I limit it to 4 or 5 people, maximum per group, because the point of each group is, let's say, Stephanie has trouble with her selective attention, and Tammy has trouble with her working memory, and I have trouble with my overall long-term recall. I mean, we're all 3 different things in the same group. You can manage that with a certain amount of people. When we start to get to 6, 7, 8, 10 people, I can't really cater things as well. It's kind of like a classroom, right? The more teachers there are to students, the better ratio you get and assistants. And we're going to group people with similarities. So I'm not going to put someone, that's targeting apples and put oranges in the same group. Does that sort of make sense? Sure. Yeah, Roz. No. She was not. No. Stephanie was not in the room then, but
they wanted to find out why we can't do or
when it will happen again. And I said that I'll be doing it at least once a month starting in October.
Yes. We're going to do it at least once a month, but it's, again, when Laura does that, it's with a big group of people, so she's not getting individualized treatment and really getting to focus on your needs, which is why I stress, and Medicare does cover for you to have an annual cognitive assessment with a speech therapist. If you have Medicare, that is something that she can bill for and actually do an in-depth evaluation with you to see what your specific areas are needed. Because it's hard when you're in a big group for her to single out every single person. So that's more of like a class. Like you go to the exercise class with Leah. It's a class, so there's a bunch of people in there. And that's what happens with cranial crunches is it's just a big class.
I don't know that choice is in either of our hands directly. To be fair, well, I also want to be fair and reach out to the rest of the community. And part of me is glad for not having the class, not because I don't love that class. However, look at how many more people in this room and on 95 that I've targeted in the same hour of time that now know what services we have available here, that may need one-on-one service or may want one-on-one service. And then they contact me and they reach out, and now I have 12 new one-on-one patients. Fantastic, because I'm here no matter what. I get paid no matter what, but I'm able to help more people. I am that hour of time have just helped 70 people instead of 7. So me reaching out monthly via dialogue like this, presentations, informative sessions, will continue to happen. So when I say I'm going to do a once a month thing, it's not just the swallowing in the lobby. It's also going to be voice presentations. It's also going to be music presentations, how music benefits the brain, all kinds of things. So the more I'm narrowed into that one class that's not expanding and opening, this is where this decision is coming from, the less able I am to help everybody.
Any other questions?
I went through a series of therapy with your department.
Yeah.
She treated me in my home here, and I felt that I gained a lot from. It was, I believe, it was 2 months.
I don't know, I wasn't with you, but yes, I believe probably about
Probably
2 months.
3 times a week, and I felt that I benefited by it greatly. She got me started on Wordle, which I'm now addicted to. And but I mean, I'll tell you, it may not be funny to you, but it's funny to me. I mean, I already did it this morning with my coffee. That's my routine.
Good.
And I go to Wordle Unlimited, where I can play many more games in
Sure.
one day. But I already forgot the word that I completed this morning.
Ah,
I'd have to go back and look at my iPad. And when my friend from Chicago calls and says, "Did you get it today?" I'd have to say, "Oh, let me go look at my paper."
so maybe what we originally targeted was your word finding and not your amount of time you're recalling. And maybe we needed to also target that.
Well,
Because
I mean, is it possible, likely that I would get another prescription from a physician?
absolutely.
Because I don't feel that I've done enough.
Absolutely. Things ebb and flow all the time. If you think of, you went to your podiatrist, he targeted your toenails, he took off any rough spots, took care of your calluses, got out that ingrown, and now it's a month and a half later, and you're like, oh gosh, I have pain in my foot. You're not precluded from seeing that person again. You can see him again, or her. Yeah.
We get residents all the time that we call, that are getting new orders for therapy that have been on in the past that come back. So that's no problem at all. Like, you use the analogy of an automobile.
Right.
We're all like automobiles and machines, and we need to get tune-ups every once in a while. So that's no problem. And Medicare understands that, and your doctors do.
Yeah, great. Good question. Thank you for that, Gail. Anybody else have any questions? Excellent. Thank you so much all for being here. I know it took time out of your day, so thank you so much, and hopefully you were able to take something positive away with you from this session.
And also, just a little plug. Next Monday evening at 7 o'clock, they requested to start having nighttime lectures again. We're going to do a nighttime lecture Monday night on fall prevention in here in the auditorium. And I'm going to be handing out flyers. I'm going to be posting them in the cubbies and everything, but next Monday night, 7 p.m. Okay? I probably did it a couple of years ago. We try to do them annually. I did. Oh, you know what I recently did was Floor is Your Friend, how to get down from the floor and up. This is fall. We're in September, right? So I figured it's fall. Let's do fall prevention. This is a different lecture.